Hello, welcome to Atropia Medic School. Today we're going to go over CHF or congestive heart failure. If you like the content, like and subscribe, and we'll get started with our questions. First question, which of the following causes pulmonary edema in congestive heart failure? A, COPD, B, hypertension, C, left ventricular failure, or D, right ventricular failure. So take a moment to think about your answer. And if you picked left ventricular failure, you are correct. Let's go to an image here and see if we can parse out why this is what we want to pick. So a little physiology regarding congestive heart failure. The biggest thing we have to worry about here, especially in relationship to pulmonary edema, is the left ventricle not doing what it's supposed to do. Why is that? The left ventricle is what pumps blood to the rest of the body. And for a variety of reasons, it can fail to do that job properly. For example, a heart attack or a myocardial infarction can do it. We can have structural changes over time to the left ventricle. It can be caused by any number of things, such as long-standing uncontrolled hypertension. There could be an actual congenital heart issue. It could be valvular problems, any number of things. But imagine over time the left ventricle burns itself out or is so significantly damaged that it can't pump blood forward. Well, just like a traffic jam, everything backs up behind it. And so the blood starts backing up. Let's see if we can change colors here. Let's do a very pale color. There we go. The blood starts backing up from the left ventricle into the left atrium. And then not drawn in here, but we have our pulmonary veins that enter into the left atrium, bringing oxygenated blood back to the heart. Well, that blood's going to start backing up through those pulmonary veins. And eventually it's going to back up into the lungs to the point where there's so much fluid sitting in the alveolar capillary membranes around the alveoli that it's just going to, the serous fluid of blood and surfactant is going to leak into the alveoli, and that's where we get pulmonary edema from. Now, this is not to say that the right ventricle isn't affected, but what happens in the right ventricle instead is we're going to get a backup of, imagine trying to pump blood into an already overfilled container. It's not going to work. We can't overfill containers. And so the blood in the lungs is just going to start backing up into the right ventricle from the pulmonary arteries. So it's going to back up. And it's going to back up from the right ventricle into the right atrium. And then it's going to back up into the superior and inferior vena cava. And over time, this is just going to burn out the right ventricle too. So the right ventricle can absolutely be affected by CHF. It's just, it's kind of the later stage. It's going to happen a little bit later. We usually see the pulmonary edema first in classic congestive heart failure, and then we start seeing the pedal edema pop up over time and the jugular venous distension and things like that. So let's go back to our question here. And this is not saying that some of these other things aren't issues, but the question is very specifically asking which of the following causes pulmonary edema. We're looking specifically at pulmonary edema. So we know that COPD more likely to cause some other stuff like right ventricular issues explicitly. Hypertension is a cause of congestive heart failure, but that is not really the thing we're going for here. Hypertension can cause lots of other issues too. And right ventricular failure, when we think of right ventricular failure, the thing that we're going to associate with that is going to be peripheral edema. Cool. Let's move on to our next question. All right, you have a 60-year-old with orthopnea and difficulty breathing for 3 days. Which lung sounds would be most indicative of CHF? A, wheezing, B, rales, C, rhonchi, or D, stridor. So take a moment to think about your answer. And our correct answer here is going to be rales. Sometimes you'll hear rales referred to on test as fine crackles. as fine crackles. And generally speaking, they're going to be bilaterally. We're not going to hear it on just one side. And that kind of makes sense when you think about, okay, the blood is backing up into both lungs from the left ventricle through the left atrium, through the pulmonary veins. It's going to affect both lungs equally. Whereas something like a pneumonia is going to affect usually one lung or the other. Not saying it can't affect both, but usually one side or the other. Now we know from some previous videos that wheezing is much more associated with asthma. Rhonchi is something we could see in COPD. We do see that in COPD. We can see this in pneumonia as well. This is where we're hearing all of the alveoli pop back open after they're getting kind of collapsed shut, atelectasis. So that's going to be for rhonchi. Stridor, we know, is airway obstruction. When we hear stridor, we're thinking an airway obstruction. So we can get rid of that answer. A couple other things that we should mention here. Some very common complaints patients with congestive heart failure may have. Let's look at orthopnea first. So orthopnea is difficulty breathing related to positioning. So positional difficulty breathing. If you probably remember from your EMS coursework that patients have an easier time breathing when they're sitting upright or they're in a tripod position because there's more distribution of blood through the lungs more equally. It's not getting circulated more. Obviously blood is affected by gravity. The vasculature in the lungs is affected by gravity. Sitting upright maximizes the amount of vasculature being perfused, whereas lying down kind of minimizes it. It's also easier to breathe sitting upright because we can use all of our muscles at maximum efficiency in order to help get air in and out of our lungs. So orthopnea is if I lay down, I'm going to have some significant difficulty breathing. Or I'm going to have issues breathing. I'm going to feel like I'm suffocating or something. It's very common for CHF patients to kind of be sitting on their issues for a couple days. That's a very common thing we see in the field. It kind of gets worse over time. It's not this immediate thing. And this kind of makes sense because over time we're getting more and more fluid buildup. We're getting more and more fluid overload, more fluids leaking into the alveoli. It's not an instantaneous process, generally speaking. Let's move on to the next question. All right. Most congestive heart failure patients present with hypertension. Why is this? A, inappropriate activation of the renin-angiotensin-aldosterone system. B, the blood vessels are fluid depleted. C, the heart overcompensates by beating significantly faster. Or D, there is an obstructed blood vessel in the heart. So spend a moment, think about your answer. And our correct answer is A, inappropriate activation of the renin-angiotensin-aldosterone system. You don't need to memorize the whole renin-angiotensin-aldosterone system flowchart. It is a myriad of things going on to compensate for a lack of perfusion. I'll mention this here, and in another video we'll talk more in detail about this. Renin is produced in the kidneys, and this is released by the kidneys as a result of not as much perfusion going through them. The kidneys are very reliant on blood flow going through them in order to filter out just stuff in general. So renin gets secreted by the kidneys through a number of processes. We convert something called angiotensinogen into angiotensin 1 and then angiotensin 2. And angiotensin 2 is going to do a number of things. It's going to cause some direct vasoconstriction. It's going to cause the posterior pituitary gland in your brain to increase antidiuretic hormone secretion. we're going to get an increase in sympathetic nervous system activity, sympathetic nervous system. So we're going to activate the sympathetic nervous system a little bit more. We're going to get an increase in things like cortisol and aldosterone. So there's a number of things that are going on here with the RAS, or the renin-angiotensin-aldosterone system. Someone whose heart is not pumping out as much blood as they should, that's going to trick the kidneys into thinking, I'm not getting enough blood. We got to get the blood pressure up somehow. We got to increase perfusion. Well, over time, guess what? This is going to make the heart try to do more work that it cannot do. By increasing antidiuretic hormone and cortisol, I'm going to hold on to more salt. I'm going to hold on to more water, increasing the amount of fluid in the system. And between increasing the amount of pressure, if you will, that I have to pump against, along with more fluid, it's going to be really hard for the heart to do its job. And this is why congestive heart failure patients have things like they have the peripheral edema, because the fluid's got to go somewhere over time. If I'm not peeing it out, it's got to get stored somewhere. We get pulmonary edema. We've kind of covered some of the mechanisms behind that. We've mentioned JVD before. And just in general, this is all in effect, not necessarily stable per se, but the patient's in cardiogenic shock, and for a while they at least will be compensating for it. So just keep in mind that congestive heart failure is kind of a form of cardiogenic shock. Maybe not our classic shock-like symptoms, but their heart's getting stressed out. Their heart can't do the work anymore that it's supposed to. So for that reason, we know that these patients are fluid overloaded. So fluid depleted doesn't make sense. The heart doesn't generally beat super fast in a lot of these patients because it's already stressed out. It can only go up a certain point in time. It's not going to be beating significantly faster. So we can get rid of that answer. That just doesn't really get to the heart of it. An obstructed blood vessel in the heart, this would be something that we would see in a myocardial infarction, or in some of or in a larger sense, an emboli, a thrombi, things like that. So we can get rid of D. That's not really going for anything. All right. A patient with a history of myocardial infarctions is visibly short of breath and has pedal edema. The patient also has been coughing pink frothy sputum. You should next A, administer CPAP, B, administer albuterol, C, administer aspirin 324 milligrams, or D, administer oxygen via non-rebreather mask. Take a moment, and we're going to pick D here. So to start off with, remember, we are in the primary assessment. We don't have that much information. We don't have that much history. We don't have vital signs. So when we're stuck in a question where we clearly have a primary assessment, ABC life threat type thing we have to deal with, we're just going to do our ABC life threat type interventions: airway stuff, breathing stuff, bleeding control, shock management. And non-rebreather mask is certainly a good way of going about it. There's nothing here telling us respiratory failure. So I'm pretty confident that we can just say, you know what, let's just flood them with oxygen, see if that helps. CPAP, we've talked about in the past, we need vital signs because we need to make sure that there's no hypotension. The patient cannot be hypotensive because this intervention will lower their blood pressure. So they cannot be hypotensive. They don't mention mental status. We're not going to worry about that here. Albuterol, not a good answer. The reason why is that albuterol is a beta-2 receptor agonist. And one of its side effects is going to be increasing the heart rate and making the heart do a little bit more work. And that's not really great when their heart is already having issues. Likewise, that's not to say aspirin may or may not be something we use, but I'm not too worried about that right now. I want to just maybe try to solve some of their respiratory issues right now, and we can figure out the rest as we get through our assessment. One thing I'll add here is the pink frothy sputum, very common, or it's commonly mentioned in questions that they'll be coughing up pink frothy sputum. This is actually related to a mixture of kind of the serous fluid of the blood along with surfactant. That's why it looks frothy, is the surfactant leaking out through the alveolar capillary membrane. Where did our question go? There it is. Haha. Last but not least, an alert 65-year-old patient has peripheral cyanosis, respiratory distress, and bilateral crackles on auscultation. The symptoms have been present for 2 days. The vital signs are heart rate 85, blood pressure 150/90, respiratory rate 24. They're still labored. And the SpO2, or pulse oximetry, is 86% on high flow O2. You should A, utilize a continuous positive airway pressure device, B, continue with high flow oxygen, C, administer BVM ventilations, or D, administer nitroglycerin 0.4 milligrams sublingual. Take a moment, think about an answer, talk it out if you need to. And we're going to pick A, otherwise known as CPAP, continuous positive airway pressure. These devices classically we think of using with our CHF patients. Think of them as creating back pressure. There is a concept when we deal with whether ventilator patients or just with respiratory stuff in general, we have something called peak end expiratory pressure. These devices create that back pressure to keep everything more inflated in the lungs. So the net effect is we keep lungs more inflated. Lungs more inflated. So when we utilize CPAP, we're going to get an oomph when we breathe in. However, we have to breathe against that same pressure. And although that's a little bit harder for, everyone, if they're using this device, that back pressure really helps to force fluid out of the way. It's going to stent to open bronchi and bronchioles. It's going to keep the alveoli generally more inflated. Another nice thing about this is that if we're, obviously these devices are O2 powered, I'm giving them a significant amount of O2, not just because I'm using high flow, but I'm also delivering at a much higher pressure. Anything delivered at a higher pressure is going to diffuse across the membrane more quickly. So if you have someone having severe oxygenation issues, CPAP may be a good tool to help improve their oxygenation and increase that diffusion of oxygen across the membrane. Now, we've mentioned this in the past. A good rule of thumb when it comes to test questions is if they're giving you continue with the same intervention and it's clearly not solving anything, you got to switch something up. So don't just keep on doing the same thing. That's just kind of insanity at that point. This patient, respiratory rate 24. Yes, the O2 sat is kind of low, but there's no indication that this patient is in failure. Their respiratory rate is elevated, but not, hyperventilating or rapid or anything like that. I don't need to pull out the BVM for this patient. And although we have good vital signs for administering nitroglycerin, that's not the issue here. I use nitroglycerin when I have cardiac chest pain. I like to refer to this as cardiac ischemic chest pain, and I'll give you some stuff here. Let's say its pressure radiates to the arms or shoulder. Arms/shoulders, or even up the neck to the jaw. Stuff like that. That is what I think of using nitroglycerin for. So that's not to say that these patients can't have some of those concurrent issues here, but they don't mention any chest pain in this question, so we're not going to think about it. I hope that helps explain some basics regarding congestive heart failure and how we treat it. Again, with everything else that we do in EMS, we kind of treat it like a stepwise fashion. If the first step doesn't work, we'll go to the next step and so forth. If you have any questions, leave them in the comments. If you like the content, like and subscribe. If you have other ideas for videos of things that you want to go over, absolutely leave a message, and we'll see you next time.